Good day. I'm Dr. Dan Jones, past president of the American Heart Association and professor of medicine and physiology at the University of Mississippi Medical Center. Today with me is Dr. Bob Carey, who's here in his role as co-chair of the new ACC-AHA guidelines on blood pressure measurement. Dr. Carey is Dean Emeritus and Professor of Medicine at the University of Virginia. Dr. Carey, thank you for being with us today. So we're going to talk about special populations. There's guidance in our new guidelines about some special populations, and Dr. Carey, I'm particularly interested in what you have to say and what the guidelines have to say about management of African American patients.
Well, thank you, Dan. As most of us know, high blood pressure is much more prevalent in African Americans than any other racial group. And also, African Americans have more significant target organ damage. So it's very important to consider African Americans and what we can do to help improve their blood pressure. So we have some specific recommendations for African Americans. The first one is that if an African American patient requires drug treatment, one should start with a thiazide diuretic or a calcium channel blocker or a combination of the two. And in fact, most African Americans who do have hypertension require a combination of two agents, and those two would be our recommended first step.
So for patients who, African American patients started on that drug regimen who don't have ideal control, is there guidance in the guidelines about the diuretic and choosing a particular diuretic?
Yes, we don't have it as a specific recommendation, but we have observed that chlorthalidone or indapamide, which are two thiazide-like diuretics, are much more effective in lowering blood pressure, particularly in African Americans. So we would favor starting with one of those rather than an ordinary thiazide diuretic.
So after the thiazide diuretic or thiazide-like diuretic, what other drugs are recommended for use in African Americans?
So all of the drugs are recommended, except that it's important to realize that ACE inhibitors and ARBs are less effective in African Americans than they are in other populations.
Does that mean that clinicians should completely avoid the use of those drugs in African Americans?
No, I think it's more a tipping of the hat toward other drugs and then adding them if they're still unsuccessful.
So I'll ask you a little bit of a tricky question. What about an African American patient with diabetes who you're trying to control? What kind of drug regimen would you build on and begin with and build on there in that circumstance?
Yeah, I would still take the African American recommendation first of a calcium channel blocker and or a thiazide diuretic and build on that.
And in those patients, what would be the goal blood pressure for those patients on drugs to get their blood pressure to or below?
130/80.
You want to say that number again, Dr. Carey?
130/80.
That's a pretty
Yeah.
new-sounding number.
Yeah, that's a new sounding number. That's right.
It is. I'll ask you if you think that's going to frustrate patients and clinicians to try to get to that 130/80, and if you think it's achievable in most of our patients.
I think it's achievable in most of our patients. It's been very achievable in randomized clinical trials, and I think it will take a concerted effort on the part of both the physician and the patient to get there, but I think it's very doable.
You're asking for some hard things, Dr. Carey.
Thank you.
Yes, you are. Now, tell us a little bit about treatment of the elderly.
So I think in the past there's been a tendency to regard high blood pressure in older individuals as just a natural phenomenon and not really dangerous. But in fact, the risk profiles show that high blood pressure in the elderly is extremely dangerous, and that one of the things that one can do, one of the few things to prolong life and ensure a happy and healthy life is to reduce blood pressure. This was beautifully brought out in the SPRINT trial, in which lowering blood pressure improved the cardiovascular risk and morbidity and mortality of older subjects greater than age 65. And in fact, even going up to more than age 80, there's still benefit. The important thing is that this works for ambulatory, free-living, older adults. And it doesn't matter if they're fit, or if they're less fit, or if they're frail. They all benefit, and the benefit outweighs the harm. There is no increased frequency of hypotension or falls.
Let's cover one more group. Tell us what the guidelines say about women who are pregnant or planning a pregnancy.
Women who are planning pregnancy or who are pregnant should stop renin-angiotensin system inhibitors such as ACE inhibitors or ARBs and substitute drugs that are not fetotoxic such as methyldopa, nifedipine, or labetalol.
Dr. Carey, thank you very much for this discussion.